big room, but you're feeling it well. Let me start by giving the floor to Gita Sen.
Thank you very much, and let me add my voice to welcoming everyone on behalf of Juan, and of course the government of Denmark and the Philippines who are our co-sponsors for this side event. My name is Gita Sen, I'm the general coordinator of Juan, and I'm here also speaking on behalf of the co-editors of the special issue of the Journal Global Public Health, which we are of course launching with this event today. A few words about Dawn. Dawn is a South-based feminist network that was founded in 1984, and we're a network of researchers, advocates, policymakers, and activists. Our work is a combination of analysis and advocacy for developing alternatives that will lead to greater gender justice, economic and ecological justice, and political transformation, and is anchored in the human rights of all people, but especially girls and women. We're very honored to collaborate in this event with the governments of Denmark and the Philippines. This side event grows out of a project that began about 2 years ago to bring more evidence and analysis to bear on the question of what we've learned from 20 years of ICPD implementation, the lessons, good and bad, the challenges that remain, and how this can help us collectively in defining a post-2015 development agenda that is evidence-based and robust in design and implementation, and fully recognizes the importance of the analysis and policy work of women's and feminist groups. The special issue of Global Public Health, which we are launching through this side event, includes 5 major review papers, an analytical overview, plus papers on integrated and comprehensive SRH services, adolescent health and human rights, SRHR in changing health systems, and sexual health, human rights, and the law. In addition, it has 13 shorter commentaries that are both issue-based and country-based, and the countries range across a wide spectrum, including Nigeria, Bangladesh, Brazil, Mexico, China, Thailand, the Philippines, the MENA region, and the state of Tamil Nadu in India. The papers in the special issue have been intensively peer-reviewed and edited, and Dawn is very grateful for the support of Canada's IDRC, and especially because we are there, through their support, able to provide open access, as you know, to the full contents of the special issue through a web link, which I hope that you've all received or seen. So with that, let me pass it back to you.
Thank you so much, Gita, and thank you also for giving the S2CCX a particular honor for me to moderate today's event, not only because the topic of today's discussion and this week's deliberations on CPD is one that is particularly close to my heart, and also one of the top priorities of my government. It's a coincidence that makes my job a whole lot easier. This special issue of the Journal on Global Health highlights many of the achievements that build on the outcome of Cairo and Beijing, and underlines that while there has been challenges in implementation, the overall trajectory is positive. So there is something to celebrate. But there's also much more to be done, as is highlighted in the journal. It highlights in particular 3 important shortfalls: inequality in access to SRH services, the quality of SRH services, and accountability mechanisms. As such, the journal highlights the importance of a rights-based approach to the SDG agenda. These 3 shortfalls are clearly linked to a failure of duty bearers to fulfill the rights of the most marginalized, to quality SRH, and of course the lack of mechanisms to hold governments accountable for these shortfalls. While this is a particularly grave concern when it comes to the health and survival of women and children, it's also a general concern for the rest of the SDGs. From a Danish perspective, it is fundamental that the issues of access, quality, and accountability are properly addressed from a human rights perspective in the final outcome if we want a truly transformative and ambitious agenda and want to see results 15 years down the road. Therefore, I'm looking forward to a particularly informative, important and interesting discussion. And I'm happy now to give the floor for opening remarks to Dr. Babatunde.
This event is, of course, very important for us because apart from all of the things we talk about in terms of advocacy, we must make sure there is evidence, and solid evidence that supports advocacy. Because that's the only way that we can justify going forward, and that's the only way we can, going forward, measure where we have been and where we're going. So this particular special issue of the Global Public Health Journal, which focuses on sexual and reproductive health and rights for the next decade, is timely because it situates our conversation in the last 20 years and indeed in the last 2 years that we've been reviewing how the world has performed with the Cairo agenda and where we need to take it going forward. And actually talking about it at this particular Commission on Population and Development is so appropriate because this is where it should be. And I'm proud that several colleagues of ours from UNFPA have contributed to this particular special issue. Laura Lasky, who heads our work on sexual and reproductive health and young people. Richard Snow, who's sitting right there, who up until 2 days ago was professor at Michigan, but now works with us at UNFPA. And also Julia Hansen, who is a rep in Ghana. And today I have a very special message. Universal sexual and reproductive health and rights of the adolescent girl is a cornerstone for sustainable development. If you don't take anything else from me today, that's what I want you to take. So I think that's most important. So, going forward, as we meet, we have the findings of the ICP Beyond 2014 report. We have a reaffirmation by UN member states of the continued centrality to development of the ICPD program of action. There is widespread agreement that increasing access to sexual and reproductive health, protecting human rights, especially of women and adolescents, would ensure a better future for all. We now have the special issue of the global public health and all the evidence, data, policy, and program experience it contains pointing the way forward. And in addition to that particular documentation, we also have Adding It Up, which is a publication that Godmaker Institute put out, which we collaborated with. That report shows in concrete terms the very significant benefits that accrue from investing in sexual and reproductive health, and the tremendous costs in lost lives and lost opportunities of failing to do so. Sexual and reproductive health and rights enables the realization of fundamental human rights. It reduces poverty, saves lives, it is cost effective, and expands economic growth and productivity. We will not achieve sustainable development, we would not achieve the empowerment of women and girls and gender equality, we will not achieve universal health unless we ensure universal access to sexual and reproductive health and protect the rights of all to access it. Sexual and reproductive health is not only a cornerstone of sustainable development, it is every adolescent and woman's and every human being's right, and we must continue to place it within the rights agenda. Sexual and reproductive rights are the foundation on which women and girls build a life of choices, empowerment, and equality. They enable individuals to have a healthy and satisfying life, decide freely and responsibly the number, spacing, and timing of their children, if they decide to have children, deliver their babies safely, ensure their newborn survive. Further, they also enable them to freedom from discrimination, violence, coercion, or gender-based violence. Since the Cairo conference, we have taken many steps forward. And together, as a global community, we have achieved many things. A 45% decline in maternal mortality ratio between 1990 and 2015, an 11.5% decline in global unmet need for modern contraception, a 21% increase in skilled birth attendance, and a decline in the rates of abortion. Yet, aggregate gains mask stark inequalities. The poorest women have the lowest coverage of sexual and reproductive health services. The poorest women and girls suffer the worst violations of their reproductive rights. So moving forward, we must focus on closing the gaps and leaving no one behind. We must focus on human rights and human dignity. I'm proud that UNFPA and WHO are launching new guidance this week on how to implement a human rights-based approach to contraceptive services. We need to do so much more to achieve universal sexual and reproductive health. We still have a long way to go to achieve this unfinished agenda. I say this because despite the progress we have made since Cairo's conference, despite the progress we have made since the Beijing Women's Conference, and despite the progress made with the MDGs, there are still 800 women dying every day from complications of pregnancy and childbirth. There are still 1 in 10 women worldwide who are married or in relationships and have unmet need for family planning. There are still 225 million women in developing countries who want to plan and space their births that lack access to modern contraception. Today, despite progress, there are still 13.5 billion girls under the age of 18 who get married every year. And when nothing is done to stop this, 146 million girls will be married before turning 18 in the coming decade. And if current trends persist, 13 million girls will undergo female genital mutilation by 2030. My friends, it is for these girls, young people and women that were here today at the UN, at the Commission on Population and Development. We need to make sure their voices are heard in the post-2015 agenda. We need to make sure that these needs are met and their needs are met and their human rights are protected. We need to take all the evidence and experience we have and use it to close the gaps and to address emerging health and human rights issues in relation to sexual and reproductive health and rights. Together, we need to continue to move forward with courage, compassion, and commitment. And every step of the way, we need to think of today's 10-year-old girl. We need to take action so that she and her peers worldwide will be able to have the information and services they need to make a healthy and safe transition to adulthood. We know that by 2030, we will need to adjust to a world of 8.4 billion people, eager to achieve higher standards of living and total freedom, while minimizing the negative effects of human activity on the environment. Africa will account for more than 40% of the absolute increase in population growth during the next 15 years. We know that the new patterns of fertility, mortality, and urbanization are unfolding. And the large youth population deserves greater attention. An estimated 44 countries, including 37 in Africa, we need to plan for at least a 40% increase in the number of women of childbearing age by 2030. This will demand a corresponding expansion and strengthening of sexual and reproductive services, including family planning, to meet their needs. We know that the number of young people aged 10 to 24 will increase from 1.8 billion today to a projected 1.9 billion by 2030. Within the next 15 years, all of the 1.1 billion increase in world's population is expected to occur in urban areas. A bold new development agenda must seize the opportunities provided by these demographic transitions and uphold the principle of human rights and human dignity for all. To achieve that, policymakers must support the power of people. Our world is characterized by an increasing mobile population with unprecedented displacement and urbanization, with people moving to seek opportunities and also to flee conflict, natural disasters, and the consequences of climate change. At UNFPA, we will respond to the rights and needs of mobile and displaced population. Thus, we are making a humanitarian response and a recovery priority for the entire organization. This, we believe, will lead to resilience building in our communities. Another priority is youth and adolescents. They are increasingly located in urban areas, seeking new opportunities for health, education, and employment. UNFPA will work to meet the needs and promote the rights of young people, especially adolescents where they live, in both rural and urban areas. Investing in youth in countries with a conducive age structure can unleash a demographic dividend to accelerate sustainable development. We will champion the 3 E's to enable nations to reap a demographic dividend: empower, educate, and employ young people. We will continue to champion universal sexual and reproductive health and reproductive rights for the full empowerment of young people and women, and work to end child marriage and female genital mutilation. We would work for safe births and meeting unmet need for family planning. The post-2015 development agenda requires robust data, and UNFPA will assume a leadership role in data for development as we move forward. Leaving no one behind requires inclusive, people-centered development and global solidarity. Together, we need to raise the level of investment in sexual and reproductive health and in strengthened health systems. We have the data from our Adding Up report. It will cost an average of $25 per woman aged between 15 to 49, roughly double the current level of spending to provide a package of essential sexual and reproductive health services to all women in developing regions each year. This investment is so little, but it is so important for our common future. My colleagues and I at UNFPA look forward to working with all of you to achieve universal sexual and reproductive rights and the future we want. A future of human rights and human dignity for all. I thank you for listening.
First of all, congratulations for the excellent issue of global public health that we are here today to celebrate. My role is to comment on the paper on advancing sexual health and human rights, the role of the law. And they have an insightful analysis of the changes of the last decades here. I don't want to put words in their mouth, but my reading of their analysis is that we have seen 2 major conceptual changes. First, while the program of action of ICPD included sexual health as a part of reproductive health, I see the authors almost saying that reproductive health is part of sexual health. There is now a recognition that there are many aspects of sexual health that are not associated with reproduction. This reversal of optics was actually already hinted at the program of action itself when it stated that the purpose of sexual health was the enhancement of life and personal relationships. The second major conceptual change in the last 2 decades, from my reading of the article, was the growing realization of the links between sexual health and sexual rights, and the increasing recognition that sexual rights are grounded in universal human rights. IPPF is proud to have contributed to this growing political international consensus, and I'm grateful to the authors for highlighting the role of our Declaration of Sexual Rights, which was published in 2008. We actually actually still do not have a formal international consensus on the term sexual rights, but at the regional level, an excellent definition was adopted in 2013 in Montevideo at the Conference on Population and Development convened by ECLA. I'm going to read the definition. States must provide public policies that enable persons to exercise their sexual rights, which embrace the right to take free, informed, voluntary, and responsible decisions on their sexuality, sexual orientation, and gender identity without coercion, discrimination, or violence, and that guarantees the right to information and the means necessary to their health, sexual health and reproductive health. So since the International Conference on Population and Development, considerable progress has been made in enacting or changing laws that affect sexuality and sexual health in line with human rights standards. Today, there is an increasing recognition that sexual health cannot be achieved without the respect, protection, and fulfillment of human rights. There is also a growing awareness that ensuring a sustainable and just world requires meeting human rights standards. As a result, many countries have enacted new laws, and the authors analyze the laws, grouping them in three categories: the legal guarantees against discrimination and violence, the decriminalization of consensual sexual conduct, and the legal guarantees of access to sexual health information and services. So all this progress has had positive effects on the health of many, especially the marginalized and poor populations. As many advocates for sexual reproductive rights can attest, overturning unjust laws and fighting for fair and rights-based policies is often an uphill battle that can take forever sometimes. Advocacy requires tenacity, patience, and resources, and the victories are often few and far between. But since ICPD, considerable progress has been made in changing and enacting these laws related to sexual health. These laws are key in setting the framework for the implementation of policies, programs, and services at the national level that allow for the enjoyment of the highest attainable standard of sexual health. An important change has been in the area of abortion, which is also a sexual right, not only a reproductive right. More than 30 countries have liberalized their laws to provide abortion on an expanded number of grounds since in the last 2 decades. In my region, the Americas and the Caribbean, we haven't seen progress. For example, we have seen positive changes in abortion laws in Mexico, in Colombia, in Uruguay, and more recently a move towards decriminalizing abortion in some circumstances in the Dominican Republic. We have also seen the removal of laws that prohibit marriage and adoption by same-sex couples in countries like Argentina, Brazil, Puerto Rico, some states of Mexico, Colombia to a certain degree. And I have a parochial complaint to the authors. They seldom mention the key changes occurring in this region, but they do mention the important examples of emergency contraception, which court after court in Latin America ruled to keep available in spite of the legal suits trying to ban it through battles to ban it, though battles remain in countries like Honduras. When it comes to the health and rights of the largest ever generation of youth, we have also seen progress. In 2006, the government of Peru amended the criminal code in an effort to protect people from sexual abuse and violence. Although its intention was to take a tough stance against sexual abuse committed against a minor by an adult, the law also criminalized all sexual activity among adolescents between 14 and 18 years old, regardless of consent. Persons caught in violation of the law could receive a sentence of up to 20 years in prison. In addition to violating the basic rights of adolescents, the law left medical practitioners unclear of the treatment they should provide to adolescents. It also left young people fearful of accessing the services they needed. In 2013, IPPF Local Member Association in Peru, in Perez, worked closely with Women's Link Worldwide and other NGOs to challenge the law as an unconstitutional violation of adolescents' right to health care. By gaining the support of the Peruvian Medical Association and collecting more than 10,000 signatures to demonstrate the public support needed to challenge the code, and the signatures were collected by the young people, the coalition successfully overturned the discriminatory law. Yet, in all regions of the world, laws still exist which jeopardize health, including sexual health, and violate human rights. We have laws that render essential health services like abortion illegal, laws that prohibit consensual same-sex relationships, and laws that criminalize the transmission of HIV, to name just a few. In order to ensure accountability for the rights and health of their populations, states have an obligation to bring their laws into line with human rights standards. These human rights-based laws, while insufficient alone, are essential for effective systems of accountability, achieving positive sexual health outcomes and the protection of human rights. Despite the successes, there is much to be done. Millions continue to face stigma and discrimination because of bad laws and discriminatory practices. In many countries, adolescents are required to seek their parents' authorization before they are able to access contraception. And same-sex sexual behavior and acts remain criminalized in 76 countries, or about 40% of all UN member states. Sex workers' rights also are not protected in many countries. There is a clear link between criminalization and high rates of harassment and violence reported by individuals. International human rights bodies increasingly call for the decriminalization of consensual sexual acts and behaviors. But national courts are not always equipped to strike down laws that have potentially disastrous health effects. Social and political movements can play a key role in upholding or reforming laws to guarantee the fulfillment of sexual and reproductive rights and health. This work entails advocating for reforms in existing laws and the creation of new legal frameworks. It also entails holding governments accountable. Increasingly, advocacy efforts are including the demand for sufficient budgetary allocations. Without resources, the most marginalized people will never be reached. Advocacy efforts are also pushing for the participation of people affected by the laws. This is especially the case of young people traditionally left out of decision-making bodies. Most importantly, given the growing popularity of anti-human rights forces, it is important to get increased support for public education about sexual health and human rights, to encourage respect for human diversity and equality. Public education is also fundamental so that people inflame them. Ensuring the sexual health and rights of all throughout their lives is a key cornerstone of development. It's not only about health, but about intimacy and pleasure that consensual, healthy sexual relationships can yield. Above all, it's about achieving happiness. Isn't that all that we want from development?
I would like to join Carmen and others that we work with in congratulating Dawn for the good work, especially in relation to this special issue. And I'm very happy that there is a focus on adolescent girls and young people, but specifically why I'm raising this as I begin to talk about what it is that the special issue focuses on is because most of the times, and I remember when I started doing my activism and work with young people, a lot of people would be saying, you know, what do we do about the energy of young people? What do we do about all the sexual energy of young people? And so it sort of spoke to the programs that I saw happening, a lot of them that had something to do with sports in nature or just protection of these young people who don't know what to do with their lives. But then again, many years down the line after the ICPD and sitting here and after looking at the evidence that has been in place, the evidence that has been looked at, is that part of it and part of the problem is that we miss the point when we work with young people. We miss the point when we put the policies and programs in place. And young people, especially adolescent girls, are never seen as people who have rights and a voice that counts. And so it becomes young people who need to be programmed, adolescent girls whose programs need to be put in place, but their voices and decisions, as Carmen has already pointed out, have not always counted. So I'm going to comment on the theme of adolescent girls and the commentary that has been done in relation to the same. The paper reviews evidence on sexual and reproductive health and rights for adolescent girls in low-income and middle-income countries. And it also, and so it highlights the policies and the programs in relation to that and commitments made since the ICPD in 1994. The paper also looks at two segments in terms of time. So the 1990s and the years after 2005 in a way to sort of demonstrate a trend in what has happened, what still needs to happen, what has changed, and the challenges that still exist. And it also maps out the opportunities because, of course, it's not just about the problems, but acknowledges that there are opportunities, especially in this time with a lot of global processes, especially the post-2015 development agenda. So one thing that stands out and is very clear is, and it's probably not new, is that countries are yet to make significant progress in delaying marriage, for instance, for adolescent girls, in childbearing, in reducing unintended childbearing, in addressing the gender disparities that put adolescent girls at risk of poor sexual and reproductive health outcomes. We're probably, you know, I know there are people who are listening to this or hear this and say, why sexual and reproductive health, whereas this is just one component of the health of adolescent girls. And I mean, the answer is not as black and white as it might seem, but there are perhaps a few things that the paper highlights that I like. One is how sexual and reproductive health actually really depends on the other health components of the whole life of an adolescent girl to be realized, for her to fully enjoy health, then it depends on the other health components. But at the same time, highlights how important it is not to miss out on that sexual and reproductive health component, because then it is in some ways very much tied to how adolescent girls experience all the other aspects of their lives. And so I will point to some of the reasons that are given why focus on adolescent girls. 580 million girls, million adolescent girls in 500 million adolescent girls in the world today, or we have 580 million girls today that are living, 88% of those are living in low and middle income countries. And so that's a huge number of girls that are potentially living in poverty or in situations where there could be a lot of discrimination or exposure to other forms of violations as a result of not being in economically, in situations that are economically putting them in a better life when it comes to education, when it comes to whether or not socially they are exposed. Some of these girls could be migrants, it could be girls that are heading households, it could be girls that are isolated because of, say, child, early and forced marriage. And so there are many reasons why they become much more vulnerable and therefore are focused. Sexual and reproductive health has remained one of the elusive of the many aspects of the health dimensions of girls, as I've mentioned, and they are usually also tied to denial of other rights, such as the lack of access to safe and informed, lack of access to safe spaces, but also the lack of access to informed choices as a result of lack of services or restrictive legal frameworks, as Carmen has already mentioned, that make it very difficult for them to be able to enjoy life and be happy. Another aspect that comes out of the paper is the improvement in sexual and reproductive health, really in as much as it depends on other health dimensions. Then for girls, there are huge implications both for their later health as well as the health of the next generation. And so it also speaks to how important it is to close the gender gaps and disparities that are related to, say, health and education, because I have to point out that for adolescent girls, a lot of people focus on education and health generally, and then we forget to look at how important that all the opportunities, those related to sexual and reproductive health included, but all the opportunities that are accorded to boys need to also be accorded to girls, otherwise then it becomes, or they are caught up in a cycle of poverty moving forward in their lives. I would like to focus a little bit on the magnitude of the vulnerabilities that I've pointed to. And I find that the paper does a good job of highlighting the convergence of what we see as intersecting and multiple forms of discrimination for adolescent girls. So if a girl is rural, she's poor, has had limited education, is socially excluded, is a migrant, or is a child as a result of other challenges such as HIV and AIDS, is a child heading a household, then it just exacerbates the problems for her. It points to other challenges such as initiation into sexual life, and this highlights two things. One, the issue of early marriage or child and forced marriage, and the issue of just being exposed to violence that could then lead to early initiation into sex. So, and this could be, like I said, it could take place within marriage or in the context of just relationships, whether they are by violence by peers or it's violence by strangers. But I find this very strange actually to talk about violence or sexual initiation in a marriage situation for a girl, because I'm trying to picture a girl, husband, you know, those two don't go together. But we do have a number of girls in different countries that the paper points to that are already in marriage situations. The thing about child marriage is that it's not just about curtailing the opportunities for girls as they relate to education and economic situations. It's also about how the situation or the gendered situation and experiences of these girls are expected to change. Suddenly a girl who is 12 is expected to perform certain roles that are always associated with being an adult woman, and some of those are really related to their sexual and reproductive rights and how that is affected. I've already pointed to the issue of sexual coercion and violence as an experience for adolescent girls. But I just want to point out that the WHO has given some estimates that, yes, that has varied from the different times that I pointed to in terms of looking at the trends. But just to mention that 29% of all ever partnered girls who are aged between 15 and 19 had experienced physical or sexual violence by an intimate partner. And then again, the issue of an intimate partner. This is also something that I find problematic, because then we are talking about not just intimate partner in terms of their peers, but intimate partners in terms of girls who are in marriage situations. So that is a problematic picture for me. And then when looking at what has happened in terms of that sexual initiation, it's very clear that a lot of adolescent girls are having unsafe sex or are involved in unsafe sex. And so it also points to how then it's not just about unintended pregnancies, unintended childbearing, it's also about exposure to sexually transmitted infections, and including HIV and AIDS, and what then it means in situations where sexual and reproductive health services are not accessible for adolescent girls, for all those reasons that Carmen has already pointed to. So what is it that could be done in moving forward, and as the paper highlights? One, it's important to ensure access to health, promoting information, and especially ensuring that there's comprehensive sexuality education. Investing in comprehensive sexuality education is actually very, very important in terms of prevention of some of the challenges, or addressing some of the challenges that I've pointed to. Two, it's important to have safe spaces or invest in programs that create safe spaces for adolescent girls. And I'm talking about safe spaces beyond what's in school, beyond what's at the family level, to having spaces where girls can actually grow the network of people that they trust, the network of where they can get information about things that they might not necessarily be comfortable to talk about within the family and school setting. Three, access to sexual and reproductive health services. I think this is something that still is actually a huge challenge, because a lot of people think that adolescent girls do not need these services. And this is an unfortunate mindset, really, that needs to change. A lot of people also say, oh, we have youth-friendly services or centers, but the truth of how young people, and especially adolescent girls, experience, or how they experience those services, from the attitudes of the health workers to just where the location of those, if it's a clinic, where it's located, is something that leaves a lot to be desired. So I want to borrow from the paper in terms of what WHO proposes for access to or ensuring sexual and reproductive health services are appropriate, they are effective, they are acceptable, they are equitable, and they are accessible for, for adolescent girls. So it's not just about labeling them, giving them a blanket, or these are youth-friendly services. It's important to look at how it is that adolescent girls themselves view those services to be actually appropriate for them and to be acceptable based on what it is that they are going through. And then lastly, the need for supportive environments. I think this is something that I can never have enough words to express that, because it's incredibly important to have girls have role models and mentors and to have exposure that actually affirms their agency or programs that are geared towards building the agency of girls, and to make sure that whatever it is we do, decisions that we make, actually take cognizance of that voice of adolescent girls, rather than thinking that it's enough to make or put programs and policies in place without actually listening to what they have to say in terms of these things. Thank you.
Systems and what it is, what kind of environment can be provided by way of health systems, what we've had, what the challenges we face at this point, and how we can go forward. One of the important things that the ICPD program of action had done was in fact to point to the great importance of the environment within which sexual and reproductive health and rights are advanced. Because if that environment is not supportive and friendly, in a different sense than what Saida just mentioned, then in fact much of what we try to do by way of advancing sexual and reproductive health and rights remains partial and not terribly satisfactory. The last 2 decades have seen really a patchwork of health sector reforms which have had very mixed results in general on equity of access and the quality of services in general, but of SRH services in particular. At the same time, our special issue also showcases examples of alternative approaches that can work and the lessons we can learn from them. As our chairperson mentioned at the beginning, among the issues that the special issue highlights, there are 3 major gaps that it points to, which are all important from the health system's perspective. One, the fact that, and they require urgent attention in the design of the post-2015 agenda. It's the indicators that will meet the targets under the Open Working Group agreed SDGs on health and gender equality. The first gap is, of course, the big problem of inequalities in SRH services, education and information, which has left the bottom 40% in terms of income and wealth quite out of the picture, as well as those in rural and remote areas. They've been left quite far behind. So the averages don't really tell us the truth in terms of what is a very, very large proportion of the world's population. The second is the very poor quality of SRH services. Now you might say that this mirrors the poor quality of health services in general in systems where health services have been quite constrained by lack of resources and so on. This is true. But when it comes to SRH services, we have added dimensions in the poor quality, and that is the added dimensions of gender bias, disrespect and abuse in service provision, which particularly affect girls and women. And these biases and this discrimination fall short, quite often means that services fall short of meeting not only human rights standards, but in general, but also public health and medical ethics standards quite often. The third big problem that we have is weak, real-time, multi-stakeholder monitoring and review, which means that we have really weak accountability mechanisms. So we can put any kind of policies and programs in place, we can legislate laws, but if we're not able to implement them seriously, we can't move forward, and that implementation really depends upon having multi-stakeholder systems of accountability in place that will ensure that we actually move forward, that will redress inequalities, that will ensure better service quality, and that will also redress and ensure that we don't have continuing violations of human rights, medical ethics, or public health guidelines. Now, quickly, what have been the impact of some of the previous and ongoing health systems reforms? We know some of these quite well. Previous existing health system reforms have functioned with constrained budgets, of rising privatization, and of user fees that have led to rising out-of-pocket spending on health. These have had damaging effects on access and equity in general, and as a result, there's now much experimentation with alternatives. But what happens when it comes to the core SRH services? And by these, of course, we mean contraception, safe abortion, maternity care, prevention and treatment of STIs, including HIV, as well as sexuality education and the prevention and treatment, prevention of violence against women, and treatment for survivors of violence, including rape. Often, core SRH services are just not included in a consistent or integrated way. If they're included as silos, a family planning silo, sitting next to a silo for maternity care, sitting next to a silo for HIV. Not only is this highly inefficient in terms of the efficient use of health system resources, but in fact it ends up with making the seekers of services run around in circles quite often because they have to run from this place to that place for each different service. Highly inefficient from both perspectives. A second big problem with the previous generation of health system reforms has been the exclusion of the needs of adolescents, and previous speakers have stressed this in a number of ways, and I'm not going to go into this. I think in addition to that, the reforms have ignored the fact that gender inequalities and power imbalances in decision-making on sexuality and reproduction have a big role in excluding people from access to services, as well as the exclusion of the recognition of the pervasiveness of violence against women and the fear of violence against women that quite often keeps people from accessing services. Another big area is that regressive financial reforms have quite often deepened the challenges faced in accessing services by girls and women, including not only adolescents, but elderly women and women in the informal economy, the overwhelming majority of working women in low and middle income countries. The irony is that when user fees for services have been removed, yes, access to services has tended to improve, but challenges of poor quality of services and disrespect and abuse of especially marginalized women and girls in healthcare settings remains. So just removing user fees doesn't do it in terms of creating the kind of supportive environment that is needed. Now, very quickly, can universal health coverage, which is often spoken about as the new mantra, the new generation of upcoming health sector reforms, really change this for the better? Let me start off by simply saying that I am absolutely in support of universal health care and coverage, but I do believe that we have to take into account some very serious caveats. And the caveats will come when I just give you when I say two things. One is the idea of universal health coverage actually underpins SDG 3, which is about ensuring healthy lives and promoting well-being for all at all ages. The core requirements of universal health coverage were spelled out by the WHO in 2013 as ensuring that all people can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So here are my caveats. Caveat 1, on equity and equality. There are many paths to universality, and not all of them will ensure greater equity of access. There is a temptation for policy implementers to pick the low-hanging fruit. And the low-hanging fruit are typically those that are easy to get to, which actually may lead you to something that has been called the inverse equity hypothesis. That those who get services early are in fact those who can win in the politics of choice and voice, so that those in remote areas, those with less voice like adolescents, poor Dalit rural women in India who are viewed as difficult to reach, get services, if at all, much later. Thereby, the push towards universality actually expands the inequality within the frame. Caveat number 2. UHC all too often focuses only on equity in terms of income or wealth inequality, ignoring the multiple and intersecting forms of inequality that can prevent access even where income may not be a challenge. And this is very, very important for us to keep in mind, especially in middle-income countries and poor middle-income groups. Third caveat, something that I call path dependence. Which services are chosen? Do we go for those services which will actually give us medium-term but more sustainable results, or do we go again for the quick return, low-hanging fruit? Let's take the example of comprehensive sexuality education. It's very difficult to show quick results from comprehensive sexuality education, but it's one of the best preventive and promotive services for adolescent health, especially for girls. Similarly, programs to prevent violence against girls and women and adolescents. Difficult to show quick results. It's going to take time. And yet, because of that, we may end up not putting in the prevention and promotion needed to make sure that we, in fact, get the results that we need. So for universal health coverage to, in fact, get us where we need to be in terms of SRH services and the fulfillment of rights, we need a combination of system improvements and services that benefit everyone, together with special attention to those whose service and program needs are great, but who may fall behind in the politics of choice and voice. Caveat number 4, quality does not automatically flow from universal health coverage, and I won't go into this in more detail. And the 5th caveat is that to get centrality of human rights and medical ethics compliance, health providers simply are at this point not receiving adequate training or supportive supervision to ensure this. And if that doesn't happen, we're not going there in terms of health systems reform. The special issue not only, of course, picks up on some of these challenges, but also draws on examples that show what can be done. So let me say then, very quickly, that in fact, if we are to move forward to ensure that health systems actually meet the needs of what we've learned are the challenges that have emerged over these last 20 years, then we really do need to address these 5 caveats in a very serious way. The good news is that we do have examples of attempts to make these changes and to move forward, and that the special issue tries to point to some of those. Thank you.
This afternoon is all about. Now let me speak to the issue on SRHR for decades. It's now more than 20 years after ICPD in Thailand. And we are at a crossroads, probably not very different from that faced by the health sector in 2000, 20 years after Alma Ata, and Health for All by 2000. We have a penchant for 20-year deadlines, apparently which always run into the political realities of 180-odd countries, trying to interpret global reform into regional, national, and even subnational realities. Our own experience in the Philippines is that we came up with the most significant reform to ensure sexual and reproductive health and rights exactly 20 years after the pilot and a little over a year ago today, which was a year and 1 week ago exactly. With that long history of struggle, and that is a common thread apparently for many countries, what that long history of struggle gives countries like the Philippines is a latecomer's advantage. And studies like these, which have been launched today, strengthen that latecomer's advantage for us, which is actually nothing more than hindsight, or what they call here in America, Monday morning quarterbacking. Our experience has shown how far ahead international policies and principles are when one considers national policies and legislation. It was the experience in the Philippines that national health and SRHR policies in particular had always been subject to the politics of the party in power. When we entered 2000, the politics changed radically, and the vulnerability of the political leaders meant that there would be no clear policy on SRHR, which is why we had to wait 10 more years. Many observers today credit the political will of the current government administration for universal access to SRH, and we also credit as well the judicial success of this policy, meaning there was a legislative hurdle, there was also a judicial hurdle that we had to overcome. The great benefit of national legislation and judicial legitimacy is that it enshrines the principles of ICPD beyond the reach of political ambivalence and ambiguity. It is now crucial for countries like the Philippines, which are implementing the principles of ICPD beyond 2015 and into Sustainable Development Goals up to 2030, to look into the three major issues that have been discussed here that have arisen in the last 20 years as we ensure sexual and reproductive health and rights for all. Number one, of course, is access to sexual and reproductive health services in the context of universal health care as a matter of human rights. Provision of quality health care, especially to the most disadvantaged groups, something that is commonly heard here as well, including those in what we call geographically isolated and disadvantaged areas, or GIDAs, we call them in the Philippines, as a matter of equity and social justice. Responsive and accountable national and local health systems as part of democratic and accountable governance. Now, access requires not only infrastructure, but a whole system of support for health provision that includes adequate and adequately trained providers at the primary and hospital, secondary and tertiary levels of care. It requires adequate facilities as well as commodities. It also requires higher investments for geographically isolated and disadvantaged areas. The functionality of health facilities is crucial because it is in reaching the last milepost of health services where the reduction of maternal mortality, reduction in teen pregnancy, and improved child survival can truly take root and be sustained. We are seeing that improved infrastructure and resources do not necessarily lead to improved outcomes, for mothers. If you are able to improve on the first two delays, which lead to maternal mortality, decision-making, and accessing health facilities, we also have to do our best to improve the quality of SRH services in the facilities that people access, which is the third delay. The heart of quality is respect for the dignity of all those seeking care. We should not allow a situation which just moves the location of maternal deaths from homes to hospitals. We should make hospitals safe and friendly spaces for women and children. And who can be more responsive to SRH than local health systems that are provided by accountable local governments? Decentralized health services that are linked to national health policies in universal health care and SRHR is one strategy to assist health systems to become competent and responsive. However, decentralization must be rational, so it does not lead to fragmentation and must be integral to the national health system, so it does not become vulnerable to be used for other ends, such as for political patronage and commercialization. Fortunately, the Philippines finds itself armed with some of the elements of success for SRH service delivery for all as we converge this responsible parenthood and reproductive health law with universal health care policies, both of which have had the benefit of national legislation. The law mandates a health system approach to maternal care through skilled birth attendance and access to emergency obstetric care, strongly supported by social health insurance, including postpartum family planning. While not legalizing abortion, the law has legalized compassionate and non-judgmental post-abortion, which will now be built into the service delivery network from the primary level up to hospitals. Most importantly, the law has institutionalized access to a broad range of modern contraceptives that have been declared non-abortive fashion. We're the only country that has to declare contraceptives non-abortive fashion by our Food and Drug Authority, and which will be subsidized by PhilHealth, our social health insurance for the poor. The major challenge for us today is to realize the promise that universal SRH services holds for all our people. Since the fight for the law has been quite public and prolonged, one can expect that implementing the promise can be intimidating. The extremely decentralized health system with 1,700 autonomous and decentralized government units is a major challenge. That's in 7,000 islands also. So is the irrational distribution of health human resources, which are still mainly in urban areas, in hospitals and the private sector. Another challenge is the continuing opposition to SRHR by religious conservatives who challenge the Food and Drug Authority certification, to recruit local government executives to declare themselves pro-life, and also we have a pending bill to nullify the law that we fought for 14 years. Hopefully, the efforts of RH advocates and practitioners in the country will embed the law in national and local government structures and processes, which will enable the program to persist even within the advent of a new presidency in next year. Apparently, 20 years for primary health care or ICPD is not enough, much less the 15 years we gave for MDs. It may be the work of a lifetime or even generations for our national systems to deliver the goals of our international ideals. Surely our people cannot wait, but we have taken the first steps here. Thank you and goodbye.